Just welcome everybody. We're really excited to see many returning faces for Keeping Kids Safe Echo today, as well as some new faces. We just want to give you a few reminders as we get rolling. As previously, your microphones have been muted, but please, we really want to hear from you. So do use the chat or unmute to ask questions as we go through today's content. We appreciate keeping your camera on when you can, and it's a-okay if you're also eating lunch as you're joining us. Please do type in your first and last names so they're visible on Zoom. I see most folks have already done that. That really helps us then get your certificates of attendance out to you. They'll be emailed at the end of the session. Today we have joining us Erica Moll. She is the Zero Suicide Program Coordinator. And welcome again. We've been fortunate to have you present in several of the other sessions and appreciate your help again today. We also have Dr. Mitchell Douglas joining us today. Dr. Douglas is a triple boarded psychiatrist and the medical director at Miralac. Again, really appreciate your expertise today. I know for many years you have a passion for community-based work, and we really appreciate the perspective you'll bring to our community today. And then we also are fortunate to have Dr. Melissa Maris join us today. Dr. Maris is a clinical community psychologist and really helping us with some of the chat. We do hope you direct some of the questions her way. Just a reminder, we don't have any disclosures today, and then we're also presenting the best evidence that we have to date with the information and recommendations shared today. After the session, the slides and recording will be sent along to you. If you do have any questions, our Telehealth ROCKS at kumce.edu email is shared. We'd love to hear from you in between sessions with ideas and questions. That said, it's a little bit different format today. We were really fortunate throughout the sessions. We got some really wonderful questions about the inpatient psychiatry setting that we're able to bring together and have Dr. Douglas's expertise. I know that, Erica, you're going to help us moderate with some of the questions we have so far, and then just really encouraging folks to type in the chat with additional questions that Dr. Douglas can help us today. So with that, I think I'll hand it over to Erica.
Awesome. Thank you, Evelyn. All right, let's go ahead and go to the next slide. So Dr. Douglas, let's just go ahead and start with if you could please provide a brief overview of Miralac services, whatever that means to you.
Sure. And first of all, can you hear me?
Yes.
Okay. And then two, I'm gonna have to back up both physically as well as just sort of make sure I understand the base. Who am I speaking with exactly? So I know my audience.
Great question. Yes, let us clear that up. So we are primarily talking with a group of folks who are providing services in school communities.
Okay.
So lots of school folks on the call.
Kind of school, social worker, counselor,
yes.
that type of role. People are actually doing the actual work with the kids every day.
Yeah.
At the highest need. Okay. So I'm Mitchell Douglas, Dr. Douglas. I'm the medical director at Miralac, which is an KU's inpatient child psych hospital located in Overland Park, Kansas, 127th Antioch. I came on board, I was the medical director of the Wyandotte Center, which is a community mental health center serving Wyandotte County from 2009 through 2015, and then started working here in 2015. coming on, you said brief overview, I'm giving you my brief overview. Came on board in 2015. At the time, there was basically 2 child psychiatrists. We started growing pretty precipitously from 2015 on. By 2019, 2020, we were up to 8 child psychiatrists with an 84-bed capacity,
Wow.
making us really on the larger side for inpatient child psych hospitals. Technically at 84 beds, we were the largest pediatric facility of any sort in the state of Kansas. With COVID, we went from double room capacity to single room capacity, and our census and some staffing dropped pretty dramatically. We were running in the 40s really through COVID. As COVID has gone from pandemic status to endemic status, it's still there, but the way we're reacting to it's a little bit differently. Have been able to expand our census some. We're now probably in the 50s as our total census capacity. That's from the history. Marillac was a cornerstones of care facility previously. It was initially staffed by KU physicians in 2015. And now Marillac was entirely bought. Every blade of grass, every rock, every brick was purchased by KU in 2017. So we are KU Health System. We're the same tax ID as KU Health System. We have the exact same standards for infectious control as if you're in the pediatric ICU. We have the exact same standards from EMTALA. We are KU Health. So I think it's something I kind of bring up because I think there's still some idea that we're Marillac, kind of sort of KU. We're KU. It's all KU employees, KU. What are we? We are a acute inpatient hospital. We do not have residential beds. So in the world of where kids go, there's been a strong movement, which I'm very supportive of, which is why I'm doing this, away from residential care and trying to keep kids as much as possible in the community and providing acute care to help them stabilize and then get back into intensive outpatient services. We're an acute inpatient hospital. We serve kids. The lowest age we'll go is probably about 4. I don't get very excited about having a 4-year-old in an inpatient psych hospital.
Yeah.
And the oldest we'll go is age 17. If they're 18 or higher, that's an adult and they go to an adult facility in our system. To be admitted to our facility, we're looking at the kids are either a danger to themselves or a danger to others with a psychiatric condition. We have developed, starting in about 2018, 2019, I took 32 beds of our upstairs, is just a dedicated unit just to help with suicidal thoughts, called our insights unit. Criteria, and I'm talking a little slow. Am I talking too fast or too slow? I should check it. Sorry with Zoom. Right.
All good.
All good? You can understand me and
Yep.
Not just mumbling. Rah, rah, rah. Okay. Our insights unit upstairs, we have pre-COVID, we had 32 beds dedicated just for suicide prevention. So those were for kids aged 12 to 17 who had the cognitive capacity to do CBT style work, so some higher level therapeutic interventions, who are not endangering others, but were likely dealing with depression or significant suicidal thoughts. Often, so that was really trying to address, got the kids showing up, and that's what I saw in 2015, 26. Kids who show up and they're depressed and they're suicidal, but the other kids on the units might be dealing with their first psychotic break. And it was kind of hard if you're depressed and suicidal, trying to work through your things, while the other clientele that we're serving are dealing with a manic episode or severe substance withdrawal or their initial psychotic episode. And so we found that by having a dedicated unit where the therapists are doing specific therapies just for that patient population, and it's you can't be aggressive on it. There's no aggression. So there's no holds, there's no restraints. It's just kids who are sad, trying to work on not being sad. That's actually been very helpful. And really, that's what I get pretty motivated about. An interesting side note, I'm talking too much, I should probably stop and ask, but when we did the split in 2019, one of the big concerns we had was going to be the upstairs unit, 32 beds, would just be these kids and they're depressed and sad and they'll get better. but the acuity of the kids who are dealing with other very real psychiatric illness, like psychosis and schizophrenia and bipolar illness, would be much more dangerous. But what we found is by making sure each unit got the appropriate care they needed, our overall results for both sides got better. So our use of physical restraint, which has gone down precipitously, went down, that was decreased as well downstairs. So that was kind of an interesting thing that sort of evolved the last 2 or 3 years.
Thank you.
Somebody ask me a question. Sorry, I'm talking too much.
Can you talk a little bit more? You mentioned that the purpose of Marillac or an acute stay is to restabilize somebody.
Yes.
Can you talk a little bit about the expectation that school folks should have when a child is admitted to Marillac? So just kind of expand a little bit more on, like, it's not a residential thing. How long would a stay be?
Yes. So
what
like,
happens there?
and that I think is the next. Okay. So the average length of stay technically is 4.1, 4.2 days. Generally, we say average length of stay is like 3 to 5, 4 to 6 days. Just like, because we're a KU health system, just like anywhere else in the health system, you know, there's no 5 days and out. If I have kids who stay here for 14 days because they're not safe to go, and so I don't really care. Like, they're going to stay until they're safe. But also they show up and they don't need to be in an inpatient hospital. I don't want to restrict a child to being a locked inpatient facility unless it's necessary. So some kids discharge after 2 or 3 days. Average length of stay is about 4 to 5 days. If you're going to the upstairs units, what happens? So if you're in am I talking to schools like around Kansas City or like far away?
Across the state of Kansas.
Across it. And we actually, our catchment area is, I mean, we get lots from the Wichita area. We get lots from, we go Dodge. I mean, we do have like a multi-state. So, okay. I'm jumping around here, sorry. One thing I would bring up, if you have a kid and they are in multiple hours away from this facility, there's not a lot of psych hospitals in Western Kansas or Central Kansas, really. I know Wichita has some services, but there's large swaths of the area where they don't. If you have a kid who's in acute crisis, if they're acute danger to themselves, I would strongly urge that they go to recommend that they go to an emergency room setting and to make sure that they're safe before you tell the family to hop in a car and drive a very dangerous 4 hours across the state to get to our facility. That's something that's kind of off topic, but kind of come up. Let me get to that one second. What should you tell family if they're coming to Marillac? If they're coming to Marillac, it's an inpatient child psych hospital. Sometimes we get confusion where a school district might refer a kid, say, hey, go to Marillac, and they're going to do an assessment. We're assessing, in our assessment team, we have a whole division that just does assessment. We're assessing whether or not they meet criteria to come in or not come into a hospital. But we're not establishing outpatient care. So sometimes families get confused. They're like, oh, the school was worried about our kids. So we came here because we're trying to find a child psychiatrist. If you're referring to our walk-in clinic, you're walking in to be assessed for inpatient hospitalization. So that, I think it's important to use it. It's an inpatient hospital, so that's what you're getting assessed for, not surprising them.
So on that topic, can we talk a little bit more about the admission process? So for instance, why might a child who seems very unwell not get admitted when they are referred to a screening to decide whether or not they'll be admitted?
So approximately 88 to 92% of patients who are a walk-in to our facility are admitted to this hospital. So about 9 in 10 end up being admitted. So it's pretty, and I know you're like, wow, I've seen some faces, but you're like, really? Yeah. Because by and large, people don't come here unless there's a really good reason. Like, you know, don't see a lot of families showing up. Like, yeah, Thursday night, 6 o'clock, I think I'll spend 3 hours being assessed in a random psych hospital. It's not the best time. The concern, which I think one of the reasons why I wanted to do this, the communication piece between what's happening in the school and when they walk in sometimes can be a barrier for us to understand what's happening. So there can oftentimes be a suddenly, amazingly therapeutic thing that happens between the school and then when they walk in our door. The kid's going to walk in our door. First thing's going to happen is they're going to be seen by a nurse to make sure there's nothing acute. Did you overdose recently? Are your vitals stable? Are you bleeding out anywhere? Okay. There's something that needs to be acutely addressed from a medical standpoint. After that, they're going to talk to our licensed assessment individual, who's going to be master's level. What can happen focusing on the school piece, what happens is you, the school counselor, sees the kid. The kid's like, I'm really depressed. I think I might want to hurt myself. I think I might want to kill myself. School counselor calls the mom. Mom's like, really? Or dad, parent, guardian, blah, blah, blah. Okay. Oh, I have to go to Miralac. Okay. They get in the car. And when they get to here, oftentimes the conversation is, when I talk to my assessment people, asking the child, what's going on? I don't know. I was just feeling a little sad and all, but I'm fine now. Mom, what's going on? Don't know. They just told me we had to come here to get cleared so we can go back to school. And then you do a CARS, or you do some sort of a Columbia rating scale, something like that, and they go pan negative. And because sometimes if we don't have that information from what's happening from the school or the outside referring pediatrician, we got nothing. I think that can be one of the frustrations of things we need to improve on, and how can we make sure we have that communication? Because if the family doesn't consent to allow us to call the school, we can't talk to the school as well.
But that is something that you do as a part of the assessment if there is a consent. So do you coordinate or communicate with schools as a part of the assessment to get that collateral information if the family consents to that?
Not always.
Okay.
I think that's the biggest thing. We try to improve on that. But the thing is, the parent is sitting there saying, I guess, oftentimes what we see, and again, 9 out of 10 of these kids are getting admitted. So, but the frustrating thing is that the family doesn't want their kid admitted, they're not going to get admitted. So there's no rules in the state of Kansas. So if the child shows up and denies, and the family's like, I don't want my child to be admitted to this facility, and there's nothing to the point where I need to call the police to take emergency care custody of the child, that kid gets referred to outpatient services.
Are there questions that would make sense from the chat to
I'm sorry, I'm not reading the chat part. I'm sorry.
Oh, it's okay. You're not responsible for that. Melissa is.
Yes, we're talking.
You don't have to worry about that.
Yeah, no, we are
Melissa
looking at the chat, and there are a lot of really great questions. Before we jump into any of them, I just want to let you all know that we will get to as many questions as we can today, and I think we're going to be able to address a lot of them. If there
How many people are out there? How many people am I talking? It was like 12.
Probably 50.
No.
40, 42.
Are you serious?
Yeah.
Yeah.
Oh crap! Sorry. Oh wow.
No.
Mitchell, you're a star.
I'm hardly a star.
So
if
we have questions that we can't get to, we will definitely get them addressed and send them out afterwards. We never leave a question. We don't orphan our questions, so don't worry about that. Please post your questions. This is fantastic. So I'm wondering. So we have some specific questions about who Miralac might be able to serve in terms of referrals. So we were, I'm a discharge planner for teens in an acute care hospital, just trying to find a bed. We are told that our only option is XYZ. Can Miralac take referrals or children from other hospitals, or kind of who can come to Miralac? Like, what kind of stipulations are there around that?
I'm just trying to follow, like coming from an outside hospital, like an ER?
Yeah, so like are there any rules of like, we will not take, a referral from Missouri, or we won't take it out of state, or it would need to be like from another community mental health center, or kind of those sorts of like,
Sure.
Are there any like basic rules?
I mean, we accept probably half of our patients come from emergency room settings, and probably the other half are walk-ins. So that's kind of our general split. We take from Missouri, we get kids from Kansas, we get kids from Iowa, occasionally Arkansas. I mean, our regional draw or catchment area, which is the technical term, is fairly wide. We got some Nebraska suddenly kicking in all of a sudden. I don't know why we're getting these kids from Nebraska. We will generally going from a medical facility to our facility is fairly common. We are not a residential care facility. So if someone's stable in a different acute psychiatric hospital, occasionally, but pretty rarely, would that patient then transfer to our facility. So if someone's at CRIT or KBC or something like that, generally they're gonna get their care there and not lateral to our facility, because the insurance companies can be like, why is that
Am I
happening?
still muted? Because I was going to expand on that.
Sure.
Sure.
So I was a discharge planner up until 2 months ago at Christie in Wichita.
Okay.
And my job was to find a crisis stabilization bed. And I called KU multiple times because we would have kids waiting for over a week for any bed. And we were
And what
told
type of- you're at like an ER setting or a PEDS floor or?
PICU,
Okay.
PICU and ER. So kids that were stable,
Uh-huh.
and then, but were still considered in crisis, had already been seen by the community mental health provider.
Right.
And
And
we
they're-
would be
and
waiting
they're at-
for a week on a bed, and I'd call KU.
Mhm.
And we were told, absolutely not, we don't take kids for psych inpatient. So that's why I was just clarifying, because if you
Wait,
do,
what?
yeah, if you do take them, I'm going to turn around and call the person who took my job and let them know about this resource.
Wait, back
That's
up.
what I
So I'm
wanted to
sorry.
make sure.
You had, I just want to make sure my information is correct. So you're at like a pediatric hospital or pediatric floor.
Yep.
And there's like a kid who like overdosed or something like that.
Yes.
And so they overdose with the intent to die.
Yep.
They're not medically stable.
And still have intent.
Yeah. And they like, they tried to kill themselves 3 days ago. So then you come to a psych hospital.
And you accept those even if it's not from
That's our bread and butter. That's all my upstairs.
Okay.
I saw 6 of those kids this morning.
All right. Thank you.
So were you calling Marillac or I'm a little confused?
Miralac, that name is new to me. And again, I was the only PEDS worker for like 6 years at that hospital, but I called the KU system multiple times because I would call KU, we'd call Stormont Vale,
Yeah,
KBC, St.
in
Joe.
Topeka, or
Yeah.
Thomas in Topeka, yeah.
We'd call Prairie View several times because they do outpatient, but they don't do inpatient. But we would
Right.
just, yeah, but I
I
wanted
mean,
to
that's
this,
like,
and I'm
I
gonna
don't,
attach
I'm not going to
information.
go into specifics of that, but like, I mean, Children's Mercy, which is
Yeah.
like, we have a very tight relationship with them, and they have the kids show up, and they, unfortunately, they show up and they overdose, or they try to shoot themselves, or whatever, and then they get stabilized, and they're there for a couple of days to make sure they're medically stable. If they're still actively medically unwell with unstable vital signs, or they can't walk or talk because they have a tube down their throat, they need to be able to ambulate generally. And by ambulate, if they have a sort of an injury that's sustained, but like I use ambulation to like, if they're still feeling the effects of the overdose to the point that they can't walk down the hallway, they need to be there for a little longer. But once they're medically stable, then they come over here. That's what we see. I wonder if you're calling, I don't know what to say. Yeah, that's where I see all morning.
I don't know what to say.
Generally, I'm trying to make sure I don't overstate stuff. So we generally, not generally, so we do therapeutic work here. It's not residential care. So if it's a long-term placement stuff, then that would be something we would be doing. Just like we're looking for a placement. That's not what we're doing. If a kid is generally, we don't serve individuals with severe to profound intellectual disability because they can't participate in our group milieu. So child with an IQ of 45 or 40 with acute aggressive behaviors would not be appropriate for our unit, for our hospital. So, and that's because if you're with that level of cognition, the services we offer we're not what. Now, that could be IQ 80, ASD, lots of social problems, and suicidal thoughts. Great, that's a lot of what we do. Does that make sense?
It does. And thank you so much for that clarification. I think just hearing you talk more about kind of the considerations and those different factors in terms of
Yeah.
kind of who who you all will then serve is super helpful.
Yeah.
I wonder if we can kind of shift gears a little bit back and kind of revisit what you were talking about in terms of the referrals that might come from a school. And the question here is, how can a school best facilitate communication with you or another kind of inpatient facility? So if there is a situation where the school has noted a concern, they've called the family is then taking that to you. Is there anything on the school side they can be doing?
If the school feels comfortable and they feel they have consent, or they feel doing it with their own legal purview in that role, they can call Marillac. This is why I always encourage my outpatient pediatricians as well. You know, if I have an outside, because this happens a lot with a pediatric standpoint. So the pediatrician sees the kid says, well, I'm going to refer over. If our assessment team, they can listen to anything. So they can call and be like, you can say anything or not, but Jimmy, I saw him in my office and he says he's going to kill himself. He's supposedly supposed, you know, mom's taking him over there right now.
So what you're saying,
So
what you're saying is
you can activate. So rather than just having the family bring him over and we lose all that communication, if you feel comfortable from a legal standpoint, looking at consent issues, communicating to Marillac submissions as well, so we can get some of that extra information.
so you could call and say, hey, there's a student from my school who's on his way over.
I saw him today and he said this.
And then Marillac will say, well, I can't confirm or deny whether or not that person is here, but I can listen to any information that you want to give me.
Correct.
Cool.
And then in that, that's super helpful. In that information that they're sharing, what are the words, like what kind of specificity are you looking for? I think I'm asking because I think this is probably one of the number one things I hear from schools is how can they be as useful as possible? So the date, the time, means, intent, like what kinds of specifics are you all listening for?
All of those things. How do I phrase it? I would avoid vagueness. I'm worried about this kid. I'm worried something might happen. Can be misinterpreted.
Be direct,
or can be interpreted by other things.
Sure.
I'm worried about this kid. I'm specifically worried that he may harm himself or kill himself. Great. Okay, now I got something. So I'd be specific is important. I asked him about suicidal thoughts and he stated blank, 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 comma, quote. He said, comma, quote, this is what the kid stated to me. Because that's going to help us a lot. Even the kid or the family says, we have no idea what you're talking about. Like, well, Christy Gagnon says, called and told us, said this, we have to take that seriously. Why did that happen? And oftentimes it can just simply be a way to open the communication with the patient. So if it's like, we don't know what's going on, like, well, the therapist at the outside school said this. Oh, well, okay.
Dr. Douglas, did you mention that Marillac uses like the Columbia as a screening tool? So if a school is using something like the Columbia or actually using the Columbia and they call and say, hey, they scored a 3 on the Columbia, would that be useful information?
That would be very useful.
So that's something I think that could be really helpful for schools to take back with them. Of course,
One thing that has me a little nervous about this conversation, and am I still on camera?
Yeah, you're good.
If you're working, and I'm sure all the schools probably have their own specific protocols based on their district, what to do with a suicidal child. That's a question, actually. Is that so?
Potentially.
I would just make sure if there's an acute danger, they need to go to the emergency room. I get very worried because if you have a kid that you're very worried that they're in acute danger to themselves or others, that they're going to shoot someone or they're going to harm themselves, if they are being transported by non-secure transport, you have no sense of what's actually going to happen. They may show up here. They may not show up here. They may not show up here and lie and say that we didn't get admitted here. You have no control of that thing. So that's just one decision tree that's on, unfortunately on you as the provider.
So then that makes me kind of think about this communication question as in terms of like who the schools are communicating with, it might be really helpful for the school to communicate with the emergency department first. If
they're in the ER, they're in a locked, secure environment, and then they're going to be assessed by that person there, and then that ER doc has to make a determination what happens next.
Yeah.
And I'm not trying to overload very busy ERs and stuff like that, but and we have walk-ins. Those walk-ins happen, but that should be part of. And I want to make sure I don't want to tell you guys what to do. That's not my job. But when I train, so I supervise the child psych fellows who will oftentimes become outpatient child psychiatrists. That's part of the decision tree. If you see some patient walks into your office, is this the level of, oh, I'm kind of worried about you, come back tomorrow? Is this, I'm worrying about you, go over to Miralac? I'm worrying about you, I need to get you in an ambulance very quickly. So that's, I mean,
yeah,
because you don't have control of that situation once they leave that visit. You know, you may be here to go Miralac. I mean, because of the lack of communication in a bilateral fashion, the kid could leave and say they went to be assessed at Miralac or they saw their outpatient provider or whatever.
So when we think about like the communication from Miralac to schools and vice versa, let's talk about discharge planning and like that communication, because schools are having a really hard time right now with the reintegration process once a student is returning to school after an acute stay.
Can I hear more about the frustrations? I've been doing this for a while. I've done stuff like that. I got the general sense, but let me hear if it's the same stuff as usual or something different.
The one that I hear most often, and y'all feel free to jump in as well, is just that students come back to school and the school might not know that there was an acute stay. The school might not have any paperwork from the hospital, like in terms of a discharge plan. And so they just don't know how best to support students once they return to school.
Yeah, and just to echo that, and even to make it shorter, that this friend has not been at school for a while, and then they show back up, and then that's it. And so then that becomes that's the amount of information that the school has, and they're not sure how to respond. Susan, I think you were trying to jump in there and.
No, if I may, am I unmuted?
Yep.
No, yeah, you're exactly right. That's just, they literally disappear and then they literally reappear. And we want to shore them up with supports and helps. And often we don't get any information. They just show back up, and business as usual obviously maybe wasn't successful. We need to maybe know what we can do differently. And often there's just no information shared.
And this is a classic and common, there's lots of legal-ish barriers. Do you find that the families are generally forthcoming with information about the hospitalization or not forthcoming?
I think in these situations, no. And I don't necessarily think that it's always about privacy. I think it's just that they don't know that they should be communicating with the school a lot of times.
Okay.
And just to add in there that I think that sometimes this is connected to kind of how the situation started. So if the episode kind of started with the school contacting the family saying, hey, this is what we heard at school, we have a concern, then that leads the family to take them to inpatient, et cetera, and that happens. Then on the way back, I think sometimes there's confusion of, if I go talk to the school, does that mean that they're going to kick my kid out again, or are they not allowed to come? And so I think there's and I just want to emphasize that I think there's a lot of opportunity for improvement in all directions. I don't think this is
this is not a complete harsh on the hospital.
Not at all. And also not I think that there's, I'll just leave it at that. There's lots of opportunities for communication.
I think we need to emphasize more. Because I can say, and our discharge, we get discharging, because I do this and I have these meetings and then I go talk to my discharge people, hey, I'm hearing this. I don't know if we have it specifically on our discharge paperwork, stating specifically, we encourage the family to be in communication with the school. I generally try to tell the families that when they discharge, We hear on this side, I hear lots of hesitancy on their part. Like, well, I don't want them to be labeled. I don't want my kid to be treated differently. They don't really need to know about my kid's medical problems. I hear a little, that's kind of what I hear a lot of. And we try to rephrase it. It's like they're here to support them. They're spending 9 hours a day in the school. And there's a whole team of people there trying to help, at least give them a heads up. But that's something that needs to get better. So that's the biggest resource and it's the most acute resource. The highest danger time period for a kid in terms of suicide is 30 days after discharge from a psych hospital. It's about 60 times the rate of it as baseline. So that is the highest risk. That can be for different reasons. Sometimes you look at it in terms of activation. They feel well enough to be able to complete. You guys understand that terminology? The activation theory. It can be they were stressed, they were in a not stressed environment, and they return to a stressed environment. But we know it. And so there's a huge push to try to get them in services within 7 to 14 days of discharge. But especially in the school idea, like, well, if they go to a school and not homeschool, there's resources. Usually, you generally will be able to see them, or at least check in, knock on, say hi within a week. Would that be generally true? No? Yeah.
Yeah, no, absolutely. I wonder, so it's so helpful to hear more about kind of the discharge process on your side. I'm wondering, so as part of your all's discharge process and just in general, even outside of your facility, it sounds like there may be some limited discussion about school, but then is there a potential for outreach directly from a place like Miralac to school if the parent or guardian consents, even if it's something fairly vague in general, like, hey, this child received treatment here. Here are 3 ways that you can support them. Make sure the school counselor says hello to them on the day they're
just like a basic kid was at Miralac because he was suicidal and discharged on the state.
Yeah. Are there efforts at Miralac or places like Miralac to actually get consent from family to coordinate with school, especially around discharge planning?
We focus the most on, unfortunately, my discharge person here. We focus the most making sure they very at least have a psychiatric appointment and a therapy appointment, and just getting that on the chart is a lot. Because we also get a little bit limited in that we are not allowed to schedule appointments for the client.
Right.
So even if I have an outpatient available at KU, I can't be like, you're going to see blah, blah, blah 2 weeks out. The family has to schedule it. But that doesn't answer your question. That's kind of like, well, okay. Your question was, what's there in place to schedule specifically with the different school districts? And I don't have a specific answer.
Yeah, I just wonder, like, and this is like big dreams, and I think this is everyone kind of would agree. It would be really helpful if like a part of the process was to ask the family at the hospital, hey, can we coordinate with your school? If yes, what are the things that we are allowed to share with the school? And then can the discharge planner go ahead and follow through with saying, hey, this student was here.
The school, yeah, because you guys, ideally it'd be like an opt-out. We're like, hey, the discharge summaries can be sent to the school counselor.
Yeah, exactly.
Unless you say otherwise.
Yeah.
I'm sure there's some legal stuff in that can't happen, but.
Yeah, I mean, I wonder if it's worth exploring.
Oh yeah, 100%.
Because I think it would be really helpful all across the board.
I concur. Give me more questions, at least stuff I can answer.
Okay, so kind of on this note, from your perspective, are there recommendations for how schools really can like meaningfully support students during reintegration, assuming that they know the student has been in an acute hospitalization stay and is coming back to school? What are the things that would be helpful for schools to do?
Present, continue to assess specifically for suicidal thoughts, recognizing that the 30 days post-hospitalization doesn't mean they're cured. Okay. We get readmissions. Technically, insurance companies don't like readmissions within 30 days. I'd much rather see a kid come back 5 days after discharge, not hurting themselves, as
Mhm.
opposed to 31 days and they try to hurt themselves. So knowing that's because that really is what you're trying to, in my mind, you're in the hospital. Hey, how was that? Was it good? Was it bad? Did you like it? Did you not like it? What'd you learn? What'd you not learn? Doing okay? Yes, no. Are you still thinking about hurting yourself? Do you want to be alive or dead right now? What motivates you to be alive? Are you still having some thoughts to be dead? Do you have any
Mhm.
plans on hurting yourself? If they're like, yeah, you know, I'm still having, like, whoa, okay, what's the plan here? Do you need to go back? You're going to see your outpatient psychiatrist later today? What's going on? Making sure that it's not just a, hey, checking in, is a checking in knowing that there's an increased risk for death by suicide within 30 days after hospitalization. So if it's their worst time, and most of the time they're better. That would be my statistically. So even though it's a much increased rate, it's still low, but that's really what you're checking for.
Yeah.
Strongly encourage participation in their outpatient care from a therapeutic standpoint and from a psychiatric standpoint. I think beyond that would be a little bit outside. I mean, medication compliance is often an issue. That's really not your role as the school counselor. If you would feel comfortable recommending continue to take your medications as prescribed, that would probably be helpful. I don't know where your rules are on that. We have expanded. We now do 60 days of meds after discharge. It's often so hard to get people in with an outside provider after discharge.
Yes.
So, but we see it over and over. Kid leaves, they're doing well, and then 3 weeks later, they stop the meds. The meds take about a week to get out of the system, and then it's 5 weeks out, and then they're sad and suicidal again. You're like, well, oh yeah, you stopped all your meds.
Mm-hmm.
Don't do that.
My biggest takeaway from what you're saying is to be really direct and not beat around the bush around like, hey, I know you were in the hospital. Let's talk about that.
Yeah.
It doesn't have to be hush hush or something to be ashamed of. Let's just be direct and talk about how was that? How are you doing now? What can I do to support you?
Exactly.
And
And
continuing
just
to
like
assess
if
suicide
you're doing social support, if you're doing school counseling, if you had a football player with an ACL tear and then you went to the hospital and had surgery, like, hey, checking in. How's your knee? You still in pain? You able to walk? How's that going? It's the exact same thing. So, hey, you had depression. You went to the hospital because you're having suicidal thoughts. Hey, how's that going? Are you able to function? Are you able to get to classes and stuff? Are you still having suicidal thoughts? It is, in my did residency in pediatrics as well as child psychiatry. It's the same thing, but instead of saying ACL tear or asthma or their type 1 diabetes, we're dealing with depression. That's it. So, and it's not getting well. Okay, hey, you went to the hospital because you have horrible asthma exacerbation. How's your breathing? Better, worse? You're doing okay? Needing resources? Oh, looks like you can't breathe. We gotta do something. Oh, how's your depression? Hey. Oh, you're still thinking like you want to hurt yourself? You have an active plan? That's not good. Boom. We know what to do next. Sorry, there's a note. There's a nurse. That's my little triple board shtick, but I do think it helps kind of not just destigmatize, but try to take the approach. And that's when I teach the med students and the residents and fellows here. What's the problem? The problem is depression, suicidal thoughts. Oh, and by the way, depression and suicidality, it's a little off topic. They are associated, but not necessarily one-to-one. So you can have improvement in depression, but still the presence of suicide or even worsening suicide.
Mm-hmm.
Generally, the two go together, but not always. So don't assume just because you've asked, hey, how's your mood? Oh, it's doing better. That doesn't stop the conversation. The need for secondary questions regarding suicidal thoughts, motivation to be alive versus dead, in my mind, is necessary. Does that make sense? Because if you have some medication, what you're really worried about, the kid feels better because they now have an active plan. Does that?
Right. Yep.
Yep. Okay. Memory stuff you already know about, but I just want to make sure that's what we see. Yeah.
That's helpful. Thank you.
One addition from when we were talking about coordination across with the school for discharge, Amber, an RN, says that coordinated care with the school health office can provide opportunities for medication administration that can help in terms of a young person consistently getting their medication. And actually that could potentially also strengthen that discharge plan.
It's a huge point because there's medication noncompliance. If there's a school nurse, I'm like, hey, they got to swing by the school nurse and take their even their antidepressant. And sometimes that gets hard, but typically most meds we like to say taking 7 days a week. But if we know they're realistically not going to get in the home environment, or it's a medication which is acutely lethal if overdosed, but also saves their lives. Just give you info, but like there's a medication called lithium. Lithium has the greatest evidence to decrease the risk of suicide, of death by suicide, of any medication we have in psychiatry. The trick is, if you overdose on lithium, you're probably going to die. So you take kids who are acutely suicidal with a history of overdoses, and then we're like, the medicine's going to help them the most is also the medicine that would kill them if they overdose on. So oftentimes we're stuck with, we know they need this, but we're very hesitant to give them. Using an outside resource like a school to be like, take it at school, the medicine doesn't go home with you. We know you're going to get it, and we know you're not going to overdose on it because it's locked in the school thing, right? Could be a great thing to think about, or a great resource.
Smart.
Yeah. Give me a little psycho farm. Don't.
Okay. So let's go ahead and move on to this next question. How is a child's family involved during the treatment and discharge planning? Both treatment and discharge planning.
So families involved a lot more than the schools. They are contacted pretty much on a daily basis by the therapist. So patient comes to Marillac, they're going to be seen every day, 7 days a week, which is different than most facilities, anyway, by a child psychiatrist. They're going to be seen by our pediatric team. If there's an acute pediatric issue, they'll be continuing to be seen by the pediatric team, which is separate and distinct. That allows us to care for pretty medically sick kids. I'm pretty proud of our pediatric team here. For the size of hospital we have a full-time pediatrician, multiple nurse practitioners working under Dr. Olinger. So, we do a pretty good job with our type 1 diabetics and our Hashimoto's and some pretty medically acute kids. They're seen every day by the therapist. So they have their own assigned therapist. The assigned therapist can make sure they do at least 1, possibly 2 or 3 family therapy sessions during their course, and then they complete their full safety planning. So those are kind of the things that happen. I mean, every day, in addition to all expressive group therapy and blah, 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 and they sing their songs and they play the ukulele and all that stuff. They're meeting the therapist every day, they're child psychiatrists every day, they're doing family therapy at least once or twice and completing a full safety plan. Those are like the check marks to get out of here. Families involved in the family therapy standpoint, they're certainly involved with the discharge planning and the safety planning. Now, the problem is, let's say the family doesn't want to. Let's say the family is not really into this whole thing. Let's say the kid's here and they have a gender identity that the family doesn't support. And so they're not engaged. It gets hard. We do look for consent from the family for all psychotropic medications. So for me to prescribe a med, I need consent from the family. For them to schedule an appointment with an outpatient provider, they have to schedule it. That's partly the community mental health centers. They won't allow us to schedule for them. So I can't call up Rediscover and schedule an appointment for someone. I can't call up Wyandotte and say, hey, make an appointment in 3 weeks for my client. Stuff like that. Does that help? Just try and keep it real. Keep it real.
Angie is asking, why has that changed? Has that changed?
What changed?
Angie, can you elaborate a little bit on what you're asking?
Yeah, so I did my internship at Stormontville West. Gosh, it's been probably 12 years ago. And I know that we were able to get like a follow-up appointment with community mental health for those discharging. It's been a while. I didn't know if that has
changed. It may have changed since then. I mean, since I've been here in 2015, it's generally been a big barrier. Because I'll go to discharge, like, oh, schedule this patient. And my discharge people are like, we can't. They won't allow it. The family.
Interesting.
Yeah, so we got a lot of that. Or the stuff that we end up putting on the books is not discharge planning is tricky. I mean, I should be a little careful with my, because I'm not the discharge planner. I'm not the one making the appointments. I try to work with them. So I don't want to give misinformation there. I feel very comfortable saying we have a very hard time with many community mental health centers and other places booking for individuals. We also have a problem where appointments sometimes get made by family or others, which are not realistic appointments, as in, like, we know that group doesn't have a psychiatrist or whatever.
Okay. Well, we only have about 5 minutes left, so I'll just ask one last question. It's pretty general. If you could give schools one piece of advice that would help you do your job or help Marillac do its job, what would that be?
I want to reach out. 'Cause I'm probably after this, I'm gonna knock on the door of my admissions person, be like, hey, I just talked a big game with 50 or 42 school counselors. And she's gonna be like, oh my goodness, what did you do, Douglas? What did you do? But working on that, because the biggest thing that keeps me up a little bit at night is the kid who's acutely ill in the home or in the school environment, and they have the therapeutic car ride and they're here. And we know something happened. We know schools don't just send kids to Marillac just because you're bored, right? And they're acutely ill and we have no criteria. And if the kid says they're fine, the mom says they're fine, dad says they're fine, and we're like, we don't know. And how can we improve that communication? How do you make you guys feel comfortable? How do I need to go talk to Laura, my admissions thing, and make sure, is there an email list with you guys or something?
I'll let Christy answer that question.
Yeah, if there's anything that you want to send out to participants later, you can send it to me and I will I'll send it on.
I think actually one, because I will just, like make sure you guys are aware of the way you can communicate with our assessment team and what type of information we can gather. I think that's my biggest thing. Like, how can we get that info? So oftentimes we'll have families, they show up, and not often, because most of the kids end up being admitted. Because in general, if we're like the school sends and the kid's like, I don't know, I'm kind of sad, we'll at least take them for a day just to figure out what's going on, because suicide is the leading cause of death, especially in the 12 to 17 population. We could debate, no, car accident, like it's like that. I worry about that a lot. It would be also helpful to make sure when you send a kid over to Marillac, just like you're being very direct about asking about suicide, also being very direct, you're being assessed for inpatient hospitalization. Because we do have that come up a couple of times a week. Family shows up and they're like, oh, we thought we're just establishing outpatient care. And they're like, no, we're an inpatient hospital. And it immediately makes it a negative conversation because they feel like they've been tricked.
That's a good point.
We're worried that your kid's in danger. Maybe you go to inpatient hospital. Why don't you go get assessed at Marillac? Go assessed for inpatient hospitalization. So those are key words, not just go get checked out. Go see what Marillac has to say. Like, they need to know they have a right to know like what you're saying. You're worried that they're acute dangers themselves. They need to be assessed for inpatient hospitalization. And what you need from me, it sounds like, is I'm going to talk to Laura, my discharge person, my assessment person. Actually, I got two pieces, the assessment piece and the discharge piece. My biggest thing, especially the assessment piece, to making sure that my assessment team knows that there's a way for the outpatient school social workers to provide information to us and what are those correct methods. Is that correct?
Yes.
I should see myself.
And then for the discharge planning piece, if it's possible to work something into like your conversations with parents where you're asking for their consent to coordinate with schools during the discharge phase, that would also be.
And that's a big one.
It is a big one. And I'm a big dreamer. So
well, hey.
I'm like, let's do it. If it's doable, let's do it.
What is KSPHQ? What is that?
Kansas Suicide Prevention Headquarters. We used to be called Headquarters Counseling Center. We're based in Lawrence, but we serve the whole state.
So you're based in, okay. I got a job.
Yes.
And you guys actually stuck with me for over an hour over a lunch break, just listening to me babble. Thank you.
Awesome.
And then we're all trying to do the same thing. We're trying to keep these kids alive, get them through adolescence, just see them get hooked up and keep themselves together as they turn into hopefully more functional young adults.
Yeah. Thank you so much for being with us today, answering all these questions. Thank you to all participants for asking lots of really great questions. Christy, is there any wrap-up stuff that you want to, since this is our last one?
Oh,
Yes, thank you, Erica, for being with us this whole series. Thank you, Dr. Douglas, for joining us today. We will send out slides and materials afterwards to your email. We also have a post survey that should be in your email now, and we really appreciate your feedback. We are planning other Keeping Kids Safe series with other topics, and it really, when you fill out the survey, it really helps with our planning for other sessions. So thank you again, everyone, today.
can I do two last things? Sorry. So
Absolutely.
I'm sorry, if I hear Christy, can you send me a quick email, just like, hey, you talked about game. You're supposed to send me an email about admission stuff.
Absolutely. Yeah.
And then two, have you done fentanyl Narcan recently?
No.
Okay, so becoming the leading cause of death in the adolescent population in the state of Kansas is people dying from opiates. And that's what's freaking me out actually the most right now, trying to do specialized training in opiate treatment.
Might be a good topic.
Yeah, how many of your schools have Narcan on site? Hopefully all of them. Not all of them, almost all of them. Okay.
I think some do.
Some do. So I would be happy to do that in conjunction with our medical toxicologist. That's Narcan saves lives.
Mhm.
We're in the middle of an acute crisis. The rate of people dying from mislabeled opiates, perk 30s, M30s, basically fentanyl at higher and higher concentrations is that's actually what I worry about as much as anything. Because even the kids who aren't suicidal, but they go home, they go back to substance abuse habits, and then they do opiates, and then it's opiate laced with fentanyl, then they die. So if you want me to give you a resource for that or do stuff talking about that, we need that's the acute thing happening right now. So off topic, but
I'll just jump in. I think we'd love to take you up on that, not just this group, but across our schools. We're hearing that as a need. So that would be fantastic to have the resources. And perhaps, Christy, we can circle back to see if we could have a pop-up or a webinar specific to that, because I know we hear from our schools that would be really useful.
Mm-hmm. Yeah, it's a great idea.
okay. Sorry, just wanted to, well.
Awesome.
All right. Bye, guys.